everybody, and I'd like to start by thanking the organising committee for inviting myself and Derek to present on this lovely topic on behalf of the young adult healthcare team in our service. Okay, so what I'm going to cover in the first section is just I'm going to look back at and provide you with a historical overview of our local service. Derek is going to present on the current and local healthcare model. I come back to you and say a few words on national guiding principles for transition, and Derek will close. So just for those of you new to our facility here, our clinical rheumatology unit spans two sides. The Rheumatic Musculoskeletal Disease Unit here at Our Lady's Hospice and Care Services in Harold's Cross, and also at St Vincent's University Hospital in Dublin 4. Bottom right of the picture there, you see the hydrotherapy pool, which represents our service here, which was established in 1961 as St Joseph's Rehabilitation Unit, a general rehab facility. And the top picture represents St Vincent's University Hospital. So our unit here, the General Rehabilitation Unit, became more specialised in 1978 as a rheumatology unit. And that was really spearheaded by Professor Barry Bresnahan, the late and great Professor Barry Bresnahan, who established the Department of Rheumatology at St Vincent's University Hospital. Professor Bresnahan trained as an adult rheumatologist in Hammersmith and Guy's Hospitals in London and the Medical Research Council Rheumatism Research Unit in Taplow. There he worked with Professor Barbara Ansell, who was described as the doyen of paediatric rheumatology in England and a world leader in the care of childhood arthritis. And through his career, he frequently referred to his training with Professor Ansell. During that time, services for children with juvenile idiopathic arthritis were as rare as hen's teeth, really, to be true. And Professor Bresnahan was probably the first person to establish what was known as a juvenile idiopathic JIA clinic at St Vincent's University Hospital. He took referrals then from paediatricians throughout Dublin and the country, and he managed children in both outpatient settings and in inpatient adult settings. And indeed, here in it was then St Joseph's Rehabilitation Unit, we nursed children to pre their death, really. I remember two in particular who died at home, but they were nursed and cared for here by this service back in those days, quite bleak. And indeed, sent back to us from Crumlin Hospital at the time to say, you know their needs better and could care for them better here in the a dedicated area led by Professor Bresnahan. He also was quite he was quite visionary, and I remember him stating, it's not appropriate that I work with these children alone as a man. And he established a multidisciplinary outpatient clinic, inviting physiotherapy and occupational therapy into the clinic, and later on myself when I was beginning to look into moving into specialist practice. So I refer to that era as the grim past, really, for children with inflammatory arthritis. I was trained and worked in the adult world, and my exposure to juvenile idiopathic arthritis, I'm going to just illustrate by a case history. And that was to a young chap in 1985. His name was Pat. He was age 23. I wasn't that much older than him myself at the time. He had systemic onset JIA, with a positive rheumatoid factor and a positive, and they were very poor prognostic indicators. He had multiple inflamed and painful joints, emaciated, sarcopenic, really, in keeping with this morning's language, clammy, bedbound, slow, robotic gait. This is what we nursed and looked after and cared for back in that era. That's how a lot of patients looked. And but what struck me about Paddy, and I knew nothing about rheumatology, it was my early days in rheumatology, he was good-humoured and not complaining about his lot, and that just struck me as being very odd because I thought he was miserable. And his response to me was, if I didn't have arthritis, I'd be in prison like most of my friends. So he saw JIA as a better life sentence. He was from Limerick City, with no disrespect to anybody from Limerick in the audience. I had trained in Limerick. I'd spent 4 years in Limerick. I'd cycled around disadvantaged years as a student midwife, so I had an understanding of what Limerick City was like, and I understood what he was telling me. And that was before some of the worst years yet to come in Limerick. But he saw this as a better life sentence. And he was miserable. In doing this presentation, he left our service some years later and moved to his own region. And I discovered through connecting with colleagues, he died probably in his 40s of comorbidities. So thankfully, I can bring you forward to 2005, 20 years later, when treatments for inflammatory arthritis became available and really revolutionized the management of these awful conditions. They induce early remission, or have the ability to induce early remission, prevent disability, and reduce the economic burden. And again, I'm going to illustrate this by a mixed emotions case history, I suppose, because if you look at the picture here, you see mother and daughter together. These are two real people who presented to our service. And I remember the presentation quite well. Mum managed to fast track her daughter to Professor Bresnahan's clinic because Mum had a diagnosis of juvenile it wasn't juvenile onset, it was onset as a young adult. And she recognized what was happening to her daughter when her daughter lost weight and complained of pain and had obviously multiple swollen joints. So within 8 weeks, she had taken her daughter to her GP. Within 8 weeks, she'd taken her daughter to a GP and requested a referral to Professor Bresnahan's clinic. And within 3 months, he had made a diagnosis. On presentation, Lisa was 16 years of age. Prof. Bresnahan moved very quickly to diagnose severe rheumatoid arthritis within that 3-month window that we speak about, of early diagnosis and intervention with appropriate medication. It's called the window of opportunity. She had very poor prognostic indicators. I think the very fact that she was standing beside her mother, who had all the hallmarks of severe erosive destructive rheumatoid arthritis, on its own right was a poor prognostic indicator. But she also had a very high rheumatoid factor titer and ANA and a CRP acute phase marker of over 100. And on that day, Professor Bresnahan co-prescribed methotrexate, and which is still the anchor drug of our immunosuppressive agents for managing inflammatory rheumatic conditions. But he also prescribed etanercept, which is a biologic therapy, and that was 2005. I think etanercept was licensed in 2002. We were only using biologics from 1999. They were very, very novel and new, and we were all a little bit scared of them. And I think it's fair to say he was probably the first person. It's safer to say he was among the first, but I'm fairly confident he was the first person in Ireland to co-prescribe methotrexate and etanercept for this patient. And that was without an evidence base at the time, but he was an international researcher, and I guess there was early clinical trials demonstrating and emphasizing the importance of the window of opportunity. This is the picture of Tara's hands on, Lisa's hands on presentation. And you can see from that picture, you can't see her knuckles, you can't see the hills and hollows. You see the discoloration over her PIP joints. And so she had polyarticular, all her MCPs and PIPs were swollen on presentation. At that time, her mother, Mary, was age 46 years of age. She had a diagnosis of severe RA, onset age 19, and she was a hairdresser at the time and was work disabled within 3 years. And they were her mum's hands at that time. So that was the fate that weighted her daughter. Really, I think it's very fair to say, without the presence of biologic therapies and the early diagnosis and the early intervention. Unfortunately, her mother died about 8 years later due to her comorbidities. Lisa is now 31 years of age, and she is in a drug-free remission. And I regret that I don't have a picture of her lovely, normal, slim looking perfect hands to this date. It would be nice to add it for future presentations. She's completed her full-time education at Trinity College. She's in full employment, and her cardiovascular aerobic activity is pole fitness. And those of you who exercise a bit more than I do realize that requires a lot of dexterity. And she also had an erosive change in her wrist on presentation. So that is a great achievement, and long may it continue. So I'm going to hand over to Derek now to present our first.
Hi everyone, and thanks to Patricia for starting the presentation off, and thanks for the organisers for inviting me. So as Patricia mentioned, I'm recently appointed advanced nurse practitioner in Crumlin, which is now known as Children's Health Ireland. So it's taken me a while to get used to the new term. Today I'm really going to talk to you about the clinic that we have between Crumlin, Vincent, Sarah's Cross, and what we do with our young patients to try and help them. So just to give you an overview of the paediatric rheumatology scene in Ireland, we're quite small. In Crumlin, there's 2 paediatric rheumatologists, It's myself and CNSs. We've clinical specialists, physiotherapists and occupational therapists, and we've medical social worker and psychology input. So we do have a whole team, and we really do need that when we're working with young people with chronic illnesses. In Tempest Street, there's Dr. Clodagh Lowry is a rheumatologist there, and she also has a team. In Crumlin, we have 3 outpatient clinics per week, that they're clinics that the consultants are at, but there are many other nurse-led and physio and OT clinics throughout. We also have patients in regularly for infusions, reviews, going to theatre to have their joints injected. We always have inpatients, and then we do 2 to 3 external transition clinics a month off-site, but 2 per month in Vincent's. So back in 2006, Dr. Orla Clean was appointed the first paediatric rheumatologist in Crumlin, and she did a lot of her training in the UK, and really the UK talked about transition for a lot longer than we have, and if you're ever at a rheumatology conference in paediatric, it's a huge section allocated to transition. So she came over with very clear what she wanted to set up, a process and a structure, and which really helped, you know, to set up the service. It really needs the whole team involved, but Dr. Clean has and still has the passion for that, so it makes it easier for us to run a good service. So she set up the continued onset clinic in Vincent's, which has continued to what we have today. So when we talk about adolescents or teenagers, just to briefly show you the wide variety of definitions in relation to age. So it ranges from 10 up until 25. And it's sort of relevant but not relevant. In Crumlin, for example, ideally we would be setting services for young people based on their developmental stage, but in fact we have to have them gone out of the hospital by their 16, and there's no other way to put it really. That's the rule. If they're not gone on our theatre, on our clinic list on a Monday, there's a big highlight 16, basically get them out. So we ignore it to certain stages, and in particular we have a large cohort of patients who have Down syndrome, so we ignore the rule for them, and they usually have many other teams involved, like cardiology, endocrine, orthopedics. So their transition and transfer is going to be a lot more complex than a patient who has one diagnosis of JIA. And just with all the change that's happening with children's health in Ireland and the new hospital, I heard only last week that there's actually talk of actually moving the transition age in the new hospital, that it might go up to 18, which would be really good. And our second rheumatologist came over from New York, and she had kept her patients till they were 21. So she had she thinks 16 is way too young, that they're really not ready to transition at all. So again, when you look at adolescence, it's generally the healthiest period in your life. And as we know, it's a period of immense change as well. And then there's these life-changing events or watershed moments. And really, that's really important for us when we're working with children with chronic illness and young people, and how that watershed moment might interfere with your disease or with your medication. So that's really a lot about what we're talking about. And we now know as well that the prefrontal cortex in adolescence isn't fully developed until early or mid-20s, and that's known as the executive suite. So that is involved in problem solving, thinking ahead, self-evaluation, and all this really important stuff. So really 16 is very young to be giving them all this responsibility to learn how to manage their own disease and health. This is a word cloud. I'm sure you've seen loads of them before, and I probably should change normal to just adolescence, because there's probably no such thing. It just shows an array of exciting stimuli and activities that occupies the life of a healthy adolescent, let's say. So if you think of everything that adolescents have to deal with now, and that we didn't have to deal with, fake tan, I never have to deal with that, thank God. And the mobile phone, of course, we know they're constantly online. They come into the clinic, the smartphone is on the desk, and you just see constant notifications coming up, Snapchat and all this kind of stuff. So they're never offline. When you look at an adolescent with chronic illness, then the word cloud loses the silver lining, I guess, and they have a lot more to think about. Their mind and their thoughts are filled with all these stimuli to do with the challenges associated with their medications, with their symptoms, coming to hospital and the healthcare team. So really, when we're talking about transition and working with young people, we're just trying to hopefully clarify a lot of this stuff for them, make sense of it for them, and help them to manage what we can as best they can. So if you, just to briefly mention the literature on transition, there's a lot of it out there, not of really great quality, but we do know that there is a deterioration in health, or that they often disengage completely with services after transition to adult services. There are reports of higher kidney graft failure rates, poor glycemic control in diabetic patients, and increase in seizure activity after transitioning to adult services. So it is important that we do focus on this and do it right, or as best we can. Young people often report to finding the actual transfer very disjointed, and that is non-consultative in nature. So again, really, we're not consulting them, we're telling them they have to go at 16. So they would prefer if they could decide themselves when they want to go. Now, saying that, most of them at 16 actually are quite happy to leave Crumlin. You know, they're usually not that sad. There's often Disney princesses on the wall, and Peppa Pig is on the telly, and Christmas Santa's coming into the clinic, and they really couldn't be bothered with any of that. They're quite happy to go. You know, we don't have a lot of upset. It's often much harder for the parents to move on, especially if they've been with us from the age of 18 months or 2 years of age. So transition is a process. Most importantly, it starts with pediatrics, but it ends with adults, and it takes everyone involved to do it properly. We need to address their medical needs, psychosocial needs, their educational and vocational needs, and helping them to learn to live with their conditions and promote lifelong health. It shouldn't be confused with transfer. Transfer is just merely the event, the handover, that passing over of care. So it's important that they're differentiated between. So just to talk about the clinic, we have aims and all the things that you're supposed to have. So we aim to improve their clinical markers or outcomes. We want to educate them, and we want them to successfully transition, so to remain in care and remain in services as they progress into adulthood. We really are trying to support self-management, encourage independence, and support for future planning. We have to have it coordinated, and the care needs to be uninterrupted, and we have to consider their age and their developmental needs and their stages as well. It has to be comprehensive and flexible. So again, we try not to transition anyone if they're very unwell and in the middle of a flare. We try not to transition anyone if they're doing their junior cert or leaving cert exams, because that, on top of the stress that's already there, can have negative outcomes. So to go through what we do at the clinic then, so we have a teenager clinic every Monday morning, which isn't the best time to have a teenager clinic for any of us, but that's what we have. So when they're 12, they come into the teenager clinic, and their first appointment is the same as every appointment. Their parents or guardian is there, or the whole family if they're up for the day out, and that's fine. And then at the end we say, so for your next appointment, you're going to come in by yourself first, and your mum or dad is going to sit just outside the room, and then they're going to come in afterwards. So that is usually received with varying degrees of dread and horror, to be honest with you. We have to kind of mind that and make sure that happens, because if we just call them, the parents are going to come in. So we have to go out and physically stop the parents coming in. And it's important you get their consent, because a while ago I brought in a girl. I'd asked the dad very quickly, I said, have a seat there and I'll be out to you in a second. Brought in his daughter, did the consultation, came out to get him, and I was met with a very angry man that was looking down on me. So he was very tall, screaming, and how dare I take his daughter away from him without, you know, so it was very unpleasant. Other people from out of the room to see what was the kerfuffle. So, you know, you really have to get everyone on board with what we're doing. When they come in then, so we usually bring in the young person by themselves. They generally say, I'm fine, everything's grand, no pain, no swelling, no stiffness, everything's grand. They generally don't know their medications. They definitely don't know their doses. They don't even know their diagnosis. A lot of them say, I've rheumatoid arthritis. Well, actually, they don't. Only about 5% of them have rheumatoid arthritis. So we have to do a lot of education, because they could have been diagnosed 10 years ago. So we need to start from the beginning and tell them what they have. Parents come in then, and then the reality comes out about, you know, things have been terrible. They're not taking their meds. You know, everything from injecting it down the sink to injecting it into a cushion, anything, you know, we've heard it all. Some parents hide their kids' methotrexate in their dinner. the kid knows it's in their dinner, they know they're taking it sometime on a Friday evening, but they said, look, if that works for them, that's okay. Some patients do have their injections given to them when they're asleep. It's definitely not something that we encourage. We have had one boy who, you know, became insomniac because of it, but it just shows the scale of how difficult it is for some young people with methotrexate, which tastes bad and makes them feel unwell. And then we have the whole needle aspect and the fear of needles and the phobia that can happen with that. So we try and work a lot with them in relation to that. So then usually when the mum comes in generally and contradicts everything that the child has said, there's often a row. It can be quite the scene. And did you tell him you're drinking? Did you tell him? Did you tell him? So of course they haven't. So then we have to talk then all about that kind of stuff. So it can be very interesting. The consultations are twice as long as they normally are. So we have the clinic cut in half to give them the time that they need. We talk about everything, nothing is sacred. Sex, drugs and rock and roll really is what we're talking about every time. They move into Vincent's then with myself and Dr. Colleen, Eamon and Patricia were there with Martina the physio and Trish the OT. So there's a lot of people in the room. It can be a bit intimidating, but it generally works quite well. It's a very nice clinic. I really enjoy going over there. Stay in that clinic until they're 20, and then at 20 we say goodbye from the paediatric side and they move into the clinic with Eamon and Patricia, who have kept the complete cohort so far. Am I right in saying that you have still see everyone from that age group that since the start? So they have had a really good process. Of course, not everyone can go to Vincent's, unfortunately, and that's the problem. What we do there is, if you look at the second stage, we do overlap clinics. So they'll have their first appointment, say in Beaumont, then we bring them back. They go to the next appointment in Beaumont and we offer them another appointment back. And we allow them to come back a few times if needed, just to make sure everything's tidied up and they're happy and that they're linked in. We want to make sure they're not lost. That's really, really important. We surveyed our patients quite a while ago, asked them how we were doing. I don't really have time to go through it all. We're not doing, I guess, as good as we thought we are. So this was the young people themselves. Anna, we're doing okay. We're doing okay. So they felt they didn't have enough preparation time, and that, you know, in the middle two, their feelings on transitions weren't listened to. We needed to improve really on, again, the middle, about them comfortable asking questions. And I think that's to do with the volume of people that can be in the room. And when there's a novel clinic on, you know, generally a lot of students want to come and see it, but if there's a lot of people in the room, that could be counterproductive for them really talking to us and telling us what's up. Again, we did pretty well on this. We need to improve on information on their overall health. Just what they identified as their top information needs is the potential of medication impact on family and fertility. So a lot of them wanted a lot more on that. Preventing long-term complications of the disease, which is actually huge, and the biggest thing that we definitely see is weight and diet and overweight, which is seen really in every clinic. Alcohol is not a big thing anymore. We don't hear it that often, or else they're just not telling us the truth. Smoking is literally unheard of in this younger age group, again, from what they're telling us. So exercise and diet and weight, it's the big things at the moment. We need to advise them how to manage the disease. If your parents are away and you're home alone, what do you do? And then how to live well with a chronic illness. So, and we have the whole team there to help us with that. So generally the feedback has been pretty good. I won't go through all of them. Just to leave you with this last bit, some of the comments that they said was, our physio had met a patient down in Galway, completely outside the clinic, and she said, "Oh, you used to come to the transition clinic," and he was like, "Yeah, what was all that about anyway?" You know, so you have to tell them that they're transitioning for them to understand the process, or else it's a bit wasted. They did comment that they're overwhelmed by the presence in the team, and I think we're very tuned in to people who are looking a bit stressed, and will naturally, just a few of us will vacate the room and let the consultation head on. And someone would like a buddy system, which really is where Arthritis Ireland, Facebook, and setting them up with a peer group really helps with that side of thing. We did kind of write all that, what I just said, down on a piece of paper, put it into the Irish Healthcare Awards, and surprisingly we won not only our category, but we won the overall award, which we didn't even know there was an overall award. so we were delighted, and it was lovely to get recognised by all our peers, and we had a great night. So that's it. I'm going to hand you back to Patricia for the last one.